Alright, this is going to be a quick kind of overview for Chapter 12. Chapter 12's information, largely what we're going to cover, is going to be rheumatoid arthritis and anti-gout medications. So the important thing to understand for both of these is going to be controlling inflammation. RA is going to be an autoimmune disorder that causes inflammation, and then gout is just another inflammation caused by increased uric acid. So for both of these, the main thing we're going to try and do is decrease inflammation, but there are certain drug classes for each one that are going to be able to help us actually decrease inflammation due to that disease process. Otherwise, there's going to be normal medication we can use to help decrease inflammation, which would be ones we already covered. So it's going to be a little bit of a review, so it's going to be good for us with these circumstances. First is going to be NSAIDs, which, anti-inflammatories, and then steroids. So we'll get into it a little bit. We'll go down to slide number 3 right away. We'll start there. So basically, what is inflammation? As we kind of touched on before, inflammation is caused by basically blood vessels vasodilating out to get more blood to the supply. And then when something becomes inflamed, it's going to hurt, right? It's going to squeeze down those nerves, it's going to cause issues. And so with that, you have the inflammation, you're going to have pain at the site. You're also going to have some redness, warmth, swelling, and then eventually you can get loss of function if the swelling is too large. This is all important because basically it's trying to get your body's way to get attention to this area in your body. Like, where I'm inflaming this, I'm causing pain, so you can look at it and protect it because something's going wrong. You need to take care of it. So normally this is going to be a protective mechanism. But at sometimes it can be a bad thing. So you can have improper inflammation. So basically when something gets inflamed, it increases the blood flow and helps trigger white blood cells to come to that area. So white blood cells are there to basically help to fight off any sort of infection, any sort of complications that have happened. But it's when they come to the site, they bring the white blood cells, the body can confuse your own body tissue for a foreign invader. So it can be an autoimmune disorder. So it causes inflammation, brings the white blood cells, and then that white blood cells actually start to attack your own body's tissue cells, thinking that it is actually what it's there to do. Okay? So basically, hold on a second. So there's two types, I had to regain my thoughts there. There's two types of inflammatory cascades. One is COX-1, one is COX-2. So COX-1 is considered as your good protective inflammation that happens generally in your GI tract, and COX-2 can be the bad swelling. So we want to try to limit the two while we're keeping the one. So as I kind of said with slide 4, inflammation is going to largely be a protective measure. It's when that protective function gets wrong, there's some sort of autoimmune disorder, and that's where rheumatoid arthritis comes in. So the whole entire goal of this chapter is relieving pain and decreasing inflammation and regaining function for the patients for whatever reason is causing that inflammation. So first we're going to talk about is rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder where the white blood cells, and the inflammation gets triggered. White blood cells come and they start to break down the bones and joints in predominantly your peripheral extremities. Your wrist, fingers, knees, joints, hands are all kind of the common places to be affected by rheumatoid arthritis. So with this, patients aren't going to feel that great because they have systemic kind of inflammation. Their joints are getting broken down. They're going to have swelling, pain, redness, and because you're breaking down the joints, you're going to decrease range of motion. So things are going to kind of get worn down on the patient. So things we can do, we can kind of look at their H&P, look at their history, There's a couple tests we can draw. We can draw the rheumatoid factor, or ESR, which is the erythrocyte sedimentation rate. The most common one is going to be C-reactive protein, and then we can always do some diagnostic tests, X-ray, MRI, ultrasound. But the ESR, C-reactive protein, and rheumatoid factor, those are going to be our tools to actually diagnose this disorder. Because they're going to be your kind of your autoimmune disorder hormones you're going to see inflamed in the body. So the whole point for treatment is they're going to be, it's not curative. It's going to help them live with the symptoms and decrease further breakdown of the joints, fingers, and kind of manage it. It's a chronic problem. So we're going to try and give them some localized control of the body and give them more control over their fingers and joints and allow them to work better. So basically we're trying to get them back to being independent, get back to range of motion, and allow them to live hopefully a safe and effective life. So the first drug we can give, NSAIDs, non-steroidal anti-inflammatories. So we've already covered those. We'll cover those again in a little bit. There are actually some specific medications directly for rheumatoid arthritis. Those are DMARDs, and then of course glucocorticoids, and we'll cover those on a little bit after we're talking about gout. So the thing to be aware of with rheumatoid arthritis is you're going to try to have some both short-term and long-term therapy. So we're going to try to manage the inflammation, manage the pain, and with that, stop and slow down the breakdown of their joints. So the first thing we're going to give our patients for rheumatoid arthritis is going to be NSAIDs. So they're non-steroidal anti-inflammatories. So this isn't going to do anything with the immune response because this is an autoimmune disorder. This is going to help with slowing down the inflammation, which is then what causes the white blood cells to come and cause that immune response. So we get a little more, we go into deeper with NSAIDs. So there's selective and non-selective NSAIDs. So the non-selectives can both inhibit both COX-1 and COX-2, and the selectives can only inhibit COX-2. So COX-2 were the ones that was the bad inflammatory pathway. So your generic over-the-counter NSAIDs, aspirin, ibuprofen, naproxen, and ketorolac, those are going to block both the good and bad inflammation. The other ones, I'm not going to try and pronounce them right now, but the other selective ones, those are only going to be to help limit the COX-2 inflammation is going to kind of help. So this is going to be great for your first line of defense. It's going to actually stop the inflammation and stop why they're actually what's kind of leading to that problem. So again, we kind of already covered NSAIDs quite a few times in this class so far, but quick review on NSAIDs. What do you want to look out for? You want to look out for kidney failure, GI bleed. GI bleed is going to be a big one, so you want to look out for the early signs of bleeding. So, because you have the increased bleeding list, but with the GI, so upper GI bleed is coffee ground emesis or black tarry stools. You also look for increased risk for bleeding, so that would be bruising or bleeding gums. Remember, you also want to keep it away from children because it causes the Ray's syndrome. And then don't forget the aspirin toxicity, which is tinnitus, hyperventilation, headache, skin changes, but primarily it's going to be the telltale sign of aspirin overdose is the tinnitus. So what do you want to tell your patient to do? You want to avoid other anticoagulants because it's going to lead to an increased risk of that risk for bleeding. You want to caution patients who already had a previous history of kidney disease, patients who have history of GERD. Alright. Next is the DMARDs, which we're on slide 13 now. If you're kind of trying to follow along, I'm going kind of quickly. I'm going to keep it succinct to what you need. So there's two types. There's methotrexate, which is a non-biologic DMARD, and then there's etanercept, which is a biologic DMARD. So both of these are basically going to be some sort of immunosuppressant. because you have an autoimmune disorder. So we want to suppress our own immune system so it's not affecting our own joints and kind of causing damage. Okay. First one is cytotoxic type 1. This is methotrexate. We want to, it's very important we caution its use in patients that want to become pregnant, both men and females trying to conceive, because it's strongly teratogenic. It's strongly category X. Will lead to spontaneous abortions. It can lead to birth defects, miscarriages. So they want to avoid this medication up to 3 months around when they're trying to become pregnant or have become pregnant. They should stop using it. Other side effects with this is going to be just kind of a general headache, nausea, drowsiness. Not a big deal, right? Let's talk about our adverse effects. Adverse effects is going to be bone marrow suppression. So when we're talking about bone marrow suppression, what is happening? We're suppressing all of our blood cells. Red blood cells are going to be anemic, going to be pale, not going to feel great. Decrease the white blood cells, increased risk for infection. So we are giving them immunosuppressant. So we do not want them to be immunosuppressed and have an active infection. So if they get an infection, what we look for? We look for telltale signs going to be a fever, then increased white blood cells, right? And then because we're affecting the platelets, going to have increased risk for bleeding. And so we want to be aware of all the signs of that. So avoid anticoagulants. Caution our use with NSAIDs because they also have that increased risk for bleeding, but we want to give both of them for that synergistic effect. So if we have NSAIDs and then methotrexate, they both come with that increased risk for bleeding. That's something we want to be aware of and we want to caution in our patients. Alright. And it can cause hepato and nephrotoxicity, so we want to be aware of our liver and kidney function. So kind of remember what labs do we monitor for liver function? That is your ALT and AST. And then for your kidney function is your BUN creatinine, and then also your urine output. So because this is an immunosuppressant, you also want to avoid giving live vaccinations to the patient because we're suppressing the immune system. That live vaccination is a higher chance of actually causing an actual infection in the patient. So the cytotoxic type 2, these are still immunosuppressants. This is Entanercept, but it kind of comes with a little less risk than the methotrexate. So we don't have to worry about pregnancy, but we still have to worry about that risk for secondary infection. So be aware of your signs of fever, increased white blood cells. We also want to be aware of Stevens-Johnson syndrome. It can lead to heart failure. So when you're going through this, I want you to review your case study number 2. It goes through, you wrote the side effects of left and right side heart failure. So what was the side effects of right side heart failure? That was the peripheral edema. The left side heart failure was pulmonary edema. Alright? And then one thing to be aware of is you need to, for both of these, you want to get tested for tuberculosis because it is an immunosuppressant. You can have latent tuberculosis, and if you give these medications, it can cause reactivation of that latent tuberculosis. So we can also use glucocorticoids and steroids for RA. We're going to cover that in the gout portion, but we already covered it, so this is a great chapter for review for us. So, gout. Gout is another inflammatory process. It's not an autoimmune disorder, but it's an inflammatory problem. So it's a form of arthritis because arthritis basically is saying inflammation in our joints. So it's caused by the buildup of uric acid in our joints, and that's where we get the complications. So normally when you have uric acid, we usually get rid of it. It's excreted through our kidneys. So we actually urinate out the uric acid. So uric acid is also highly prevalent in things that were high in purines. If you're wondering what kind of was high in purines, kind of think of the same things as your MAOIs. What foods were higher in tyramine? They're kind of pretty much the same. It's your organ meats, kind of your shellfish, and things like that. So things are kind of high in, like, high caloric foods. So basically what happens is your body usually excretes uric acid, but now you're getting so much uric acid, the body can't handle the increased uric acid. So what do? You're going to deposit it in your joints. And that deposit in the joints is going to cause pain, swelling. It can eventually lead to the joints themselves to kind of get broken down. Also remember what medications led to an increased uric acid, and that was diuretics, which seems kind of odd because we should excrete uric acid, but because we're causing the kidneys to diurese so much more, will actually cause our body to reuptake certain things, and we can end up reuptaking that uric acid, and we're not able to excrete it as well, leading to increased uric acid in the body. So if you have increased uric acid and you're urinating it out, but your kidneys can't handle it, so what's going to happen is basically it will build up in the kidneys themselves, and it'll actually lead to kidney stones. So they can be at high risk for kidney stones. So moving on to slide number 17. So basically, what is the goal of therapy? So the goal of therapy, again, is decrease inflammation. How do we decrease inflammation for gout patients? Well, gout patients have increased inflammation from the increase in uric acid. So that's why we want to decrease uric acid and then reduce the inflammation, and also we can help control the pain. So we can give medications that will decrease uric acid, glucocorticoids, and NSAIDs. So NSAIDs, I probably should mention this with RA, but why are NSAIDs so important? So NSAIDs are not only anti-inflammatories, but they're also analgesics, right? So they help with pain relief. So for the gout medications, we have the uricosurics, which are basically going to help decrease and lower uric acid levels, and then the glucocorticoids, which are going to help actually treat the inflammation and also help with the autoimmune disorders, which was more your RA, not your gout. Your gout is just your anti-inflammatory. So your uric acid reducing medications is allopurinol. This is kind of our main one. So gout is, again, a chronic problem. Allopurinol isn't going to help decrease uric acid in the short time. It's going to kind of slowly lower down uric acid levels long term. So it's a chronic control medication. So it's not going to help with the acute gouty attacks. So basically what you want to be aware of is it's going to break down the uric acid crystals and cause your body to excrete it. So breaking down those uric acid crystals is going to cause worsening pain. So the problem is that you want to, again, how can we help treat this? Treat it with an NSAID, analgesic, anti-inflammatory, kind of help with both sides. So your side effects and adverse effects are, we can end up leading to kidney damage because we're causing the kidneys to excrete more uric acid than it's used to. Also, we're causing them to excrete more solid material, the uric acid, leading to an increased chance of, again, kidney stones. So it's things we want to be aware of. Also, it can lead to cataracts, so it can affect people's vision. So they should get a vision test at least once every year when they're on this medication. Again, it can lead to heart failure, as I said, kidney stones, and then leading to kidney failure. It can also lead to liver failure. One of the adverse effects is actually a stroke, and that's going to kind of be because you're dissolving the uric acid crystals back into the blood. You have more solid particulates going through the bloodstream, and when you have more solid things in your blood, you have a higher chance of causing a stroke, causing a blockage. Next is probenecid. Probenecid is another medication that's going to help be used to decrease uric acid levels. And we're trying to break down uric acid levels and excrete the uric acid through the kidneys. So we have to make sure we are having proper kidney function. And one thing we can do to help decrease risk of renal calculi or kidney stone is to increase your fluid intake, so you can kind of wash things out long term and not have so many issues. Alright. In treating these medications, you also kind of be aware of what your uric acid levels are. So generally speaking, it is different for male and female. Female is generally 2.4 to 6, and I think male is something like 3 to 7. So it's kind of be aware of your general range of 2.4 to 7, and that's going to be your normal range. So anything above that is too high. So you know your medications aren't working as well, and they're not doing what they need to do. So for all these medications, again, as I said, you want to increase your fluid intake. It's going to kind of help with the kidney function, help decrease medications from sitting in the bloodstream so long and damage the kidneys, also help excrete out some of the uric acid crystals. You want to avoid foods that are high in purines, because that's what your body breaks down into uric acid. So if you have gout, you want to avoid those triggers. So your meats, your alcohol processed foods, wine, shellfish, fish in general, you want to try to avoid those. So next, again, is going to be a review of the glucocorticoids, so your steroids. So what did our steroids do? Well, they were anti-inflammatories, right? They worked by decreasing inflammation, which was the good thing, but also had a whole list of side effects with it. They led to fluid retention, weight gain, and with that fluid retention, you got increased blood pressures. You got bone marrow suppression. With the bone marrow suppression, you got the increased risk for bleeding. Increased risk for bleeding, I mean, bone marrow suppression, you got increased risk for bleeding, so you got increased risk of bruising, bleeding gums, GI bleed, increased risk for infection. You also got the decreased red blood cells, so you got the anemia, so they're tired and weak. You got the hyperglycemia, so increased blood sugar, so I always have to caution your use in diabetic patients. It also led to the osteoporosis, so the weakened bones, Cushing's syndrome, which was the basically facial swelling, the buffalo hump, the swelling in the back, edematous in the body, muscle wasting, which is not good. So what are we going to do for these patients? So one, we want to kind of manage their symptoms. So manage the blood pressure, manage their heart rate, assess their weight. Are they retaining a lot of fluid? Monitor their blood sugar levels. Monitor their I's and O's. Are they getting as much out as they are getting in? And then we want to, because we can lead to some hypoclemia, we want to monitor the potassium levels. And one thing to be important with steroids is remember you always want to taper down your dose. You never want to stop abruptly. And then when it comes to steroids, you can monitor your C-reactive protein, and that's kind of one of your inflammatory proteins we saw with RA. We can kind of monitor that and get its effectiveness. So who do we want to avoid giving a steroid to? Well, one's going to be someone who has an active infection. Getting live vaccinations is not going to work very well. Patients with heart failure can't handle that increased cardiac workload. Peptic ulcer disease, GERD, because of the GI bleed symptoms. Patients with diabetes, hypertension, kidney failure patients, myasthenia gravis patients, and then also patients with osteoporosis. So the last part of this PowerPoint is a little bit of review on vaccinations. They were also in, I believe it was chapter 17. So what do you need to know about immunizations? Basically, what you need to be aware of is kind of that last slide, which basically says like our nurse's role is vaccination safety. So we don't want to give live vaccinations to anyone who's immunosuppressed. We want to assess the sites of injection for redness and swelling. We also want to make sure that people are getting proper immunizations as they should. And we also want to basically keep patients as healthy as possible, so be proactive with vaccinations. And this is kind of the entire quick review of Chapter 12.